do a jaw thrust maneuver. All right, so that might mean somebody else coming in just for the intubation. Just say, okay, listen, I just need to borrow you for 5 minutes. Just come and help them with this airway. Right, so it's positioning of the patient. If it's a very fat patient, you might want to just elevate their shoulders a little bit, sort of put their head into the sniffing position, get your good lighting. Who wanted good lighting? Okay, put the bed at the right height, take the irritating bed head off the end, position the patient so that you can actually intubate them. Okay, so we've talked about preparation, we've talked about positioning. Now we come to pre-oxygenation. Okay, so we're going to pre-oxygenate the patient. If the patient is breathing, you can use this mask. Some people find it extremely claustrophobic. They might not tolerate it very well. Just loosely on the face with an explanation and coordinated with their breaths. Okay? If they are comatose, GCS less than 8, what you can do then, can I have a tongue depressor? You don't need the tongue depressor if you've got a laryngoscope, but I want to just use the tongue depressor to show you how you're supposed to do this. So at the level of the incisors, and generally pressing your lips down onto your incisors is going to give you that level. Find the angle of the mandible, and don't ask for orange or green, because different people make them and then they're different colors, okay? At the angle of the mandible, this one's too long, alright? So we might want to do a slightly shorter one, okay? At the angle of the mandible, there, that's better, okay? So oropharyngeal tube, use your laryngoscope blade, or your thing, your spatula, and pop it in, okay? Now we're going to bag, and because somebody asked for extra masks, when this one didn't make a good seal, we could take another one, all right?
So I just want to quickly ask,
yeah.
With that, don't you first point it upwards and then
No. Do you know, unfortunately, when you start as medical students, you get taught a certain way by one person, and then all the guidelines change, and now they say, I mean, it never ever made sense to me personally, but now officially, we don't do that anymore, all right? What he's saying is, and you'll still see a lot of people doing this, is put it in this way up, because that way, you're not pushing the tongue. There's no way that you can push the tongue down into the back of the throat. That's the theory behind it. But unfortunately, that rotation causes a lot of trauma to and unnecessary swelling to the soft palate. All right? So we're not putting them in that way anymore. We're using a tongue depressor or a laryngoscope blade, and we're putting it in it normally. And you'll see when you start doing this yourself, it's actually just such a pleasure, because now when I do this, I'm doing a quick Malin party. I'm seeing if I can see, as I said to you, the uvula, the tonsils, and everything. So it's something you should be doing anyway, because it's going to help you prepare better. All right? Okay, so we're pre-oxygenating 6 breaths or 3 minutes in a breathing patient, because we did get our oxygen source and we did turn it on at the wall at 15 liters per minute. Okay, bagging the patient nicely now. Pre-oxygenation. Now, the little group in the back there that suggested all the drugs, we're going to paralyze with sedation. All right, the P is not because paralysis becomes first, it's just because it's P. Paralysis with sedation, so we're going to give the sedative. I like etomidate. All right, in an adult, you give 20 milligrams. You give it as a push. You follow it immediately with your paralytic. If you are sure, because you just did all these evaluations when you evaluated your patients, I'm happy to paralyze this patient, and you give the paralytic. If it's somebody that's arrested, it's a completely flat top patient, please don't paralyze them, they're paralyzed already. Okay? If they've got anything that looks like a gag reflex, or if they're clenching your teeth, you're not going to get anywhere. You're not going to get anywhere close to their vocal cords, let alone through their clenched teeth if you don't paralyze them. So sometimes you have no choice. Okay, so you paralysis with sedation. Okay, so now finally we get to passing the tube. Okay, so you're passing the tube, you've got your patient. The patient's a little bit far down the table. I'm just going to get rid of those. Passing the tube. So various things that we can use to help us get the tube in. I think it's a reasonable suggestion just to start with the usual stuff. Is the ET tube preloaded with this introducer. Your suction's ready. and your McGill's forceps is ready. And these are all things that you're going to hold in your right hand, so you put them on the right hand side of the patient, and get into the habit of leaving the stuff on the side on the patient that you are going to pick it up in. Okay? So the laryngoscope blade gets put down on the left hand side of the patient. Then you know it's there when you want to pick it up again. Okay, so pre-oxygenated, we've got somebody doing positioning. I put the laryngoscope, hold the laryngoscope in my left hand at the handle. Alright. It's much more difficult to control it if you're holding it down there. So don't hesitate to put your hand right actually on the blade. Alright, so you put it in the right hand side of the patient's mouth, sweep the tongue across to the left hand side, get your ET tube. Notice where the black line is, because that's going to be at the actual vocal cord. So pass the laryngoscope all the way down to the patient's. Oh, this one's battery split. You just need another handle. So what you're doing is you're basically crawling down the tongue slowly until you're in the vallecula. In other words, you're always looking at the epiglottis, and when you're in the vallecula, what you want to do is just push the whole lot.
Well, we know, but the thingy, they don't work, there are no batteries in them all, so